where before it was just fatigue before that, just regular fatigue and malaise. What about the CDC? So what is their definition? It's pretty similar, but they go maybe a little bit into more detail, right? The fatigue is accompanied by illness that lasts 6 months, and you've got pharyngitis, cervical axillary tender lymph nodes, headache, arthralgias, persistent muscle pain, difficulties with memory, concentration, sleep, and increased malaise, right? More than just your regular run-of-the-mill fatigue. And these people, obviously, they feel good one day and they feel great, and all of a sudden they feel struck down by something. And that's a pretty hallmark, story that people tell you. And what's interesting with this, you probably noticed that there's a huge overlap of fibromyalgia, which we'll talk about later. So really kind of how many people have this, right? And it's my practice, and probably your practice as well, is quite skewed to the fact that we're seeing a higher preponderance of these people. Plus, this is also people who are willing to go to the doctor and get diagnosed. Most of them just say, well, I'm tired all the time. So here was one study where they looked at 4,000 patients in a health maintenance organization. I think it might have been Kaiser or something, where they looked at SCID, range from anywhere between 75 to 267 cases per 100,000. It's a pretty wide range.
Todd, I hate to interrupt, but some of our people don't have sound.
Okay. But can you hear me okay?
I hear you fine.
I hear fine.
I hear you fine also.
Okay, I got at least two. I got Mike Pierce and Marie. Anybody else? Put it in the chat if you can't hear.
Yeah.
No, I'm doing well. I can hear and see everybody.
Okay.
All right. So everybody's back. Everybody's good now.
Okay. Yeah.
Okay.
Just let me know if that happens again. Sometimes I'll mute and unmute and kind of see me in the shadows coming in and out here.
So I think if you're not getting the sound, if you go out of the meeting and come back in, I think that might do it. So okay. Sorry to interrupt.
No worries. And then let me know if other people can't hear. We can always stop and try to.
All right. Anybody you can't hear, put it in the chat for me. Okay.
So if you didn't meet the IOM overly strict definition, now your cases are tripling. But look at this range, right? 775 to 6,321 per 100,000 people. Some data showing that really the prevalence is anywhere between 0.3 to 2.5%. And in my practice, it's a lot higher because people are really coming to see me for that. And they get referred quite a bit because I was part of the fatigue super conference 1 and 2. And that just sent people all my way all over the world because they're obviously very sick. Females comprise 75%. And I personally think that's because more females go to the doctor than men. And there's also quite an overlap with fibromyalgia. And it primarily affects young to middle-aged adults. So what are these kind of signs and symptoms, which we went over previously, but it's this relatively sudden onset, and it's often associated with a typical infection, such as an upper respiratory infection or true infectious mono. And the reason I like to point these out is because as I'm taking someone's case, I'm like, what were you like before you were sick? And then what we like after. And if they're telling me that they got sick, then I know it's going to be more likely an infectious cause. Many people don't really even remember getting sick. This is even more prevalent now with COVID and these long haulers. I'm treating them like chronic fatigue syndrome with more antiviral support, and it seems to be working out pretty well so far. But more ebbs and flows to these cases. Overwhelming fatigue, several additional symptoms, altered sleep, cognition, excessive physical activity. And I would go even actually back a step from that. These are individuals that can be so fatigued, and this is what I see a lot, and you do probably as well, is that they're like, I walk 2 blocks in my neighborhood and I'm in a flare and can't move for 2 days and I'm bedridden. So it's not even excessive physical activity. They've been so sick for so long that even, a small modicum of exercise or activity wipes them out. But it doesn't even have to be physical. I get people that it's like an emotional thing where they have to use their brain or, go to work and they're wiped out. And then a lot of these people end up with disability and spend, their entire life savings trying to get better. Affected patients typically, they're highly functioned and they're struck down, and there's often a history of psychiatric disorders. And this is the definitions right from the conventional journals. But is it the chicken or the egg? And I will ask people that. I'll say, if they talk about a lot of depression, a lot of anxiety, I'll say, were you an anxious person before you got sick? Did you have this? And I would say 50-50. They might say, oh yeah, I was kind of always a nervous Nelly. And then the other ones are like, no. So is it the disease that's really causing them to be, depressed or anxious or both? And if I felt like they did, I'd probably be pretty depressed too, where I couldn't even, go for a hike or do things that I love or paint or draw or whatever their passions are. So why is it so difficult to diagnose? Well, once they've had an illness, if any, right, physical exam is totally normal. And so many times what I'll do is when they're in a flare, if their disease ebbs and wanes, I'll ask them to, take their temperature or come in for a quick physical exam. Now my practice is 100% telehealth and has been for 3.5 years, but I would have them come in then so I could feel their lymph nodes and do more physical exam while they're sick, not while they're in one of their, they're not in a flare. And of course, they say they may feel febrile, but they rarely have elevated temps. That's in office. But if you have them do their temps when they're sick, many times, unless they have hypothyroidism, many times they do have a slight fever. They're slightly febrile. And then they have joint pains, but no swelling, no fusion, no redness, no limitation of motion, but they feel internally like there's problems, right? Easily fatigued per their report, but when you do muscle testing, right, it's all +5, maybe +4s. Biopsies are normal, electromyograms are normal. This is pretty interesting because, up until relatively recently, and I think most of the world still thinks that chronic fatigue syndrome is a, a mental illness, not a physical one, that these people will have mild cervical and or axillary lymphadenitis with painful lymph nodes, like lymphedema, but no lymphadenopathy. But if you biopsy them, they will show that there is increased swelling of the lymph nodes, the lymphocytes. So we know that there's something going on. It's not all just in their head. And that's part of what I'm doing in these intakes with the individual if they present like that, where they're just like, nobody ever believes me, I'm sick. It's just normalizing the situation that they're not crazy. It's not all in their head. And right, that's part of the therapeutic encounter, is to let them know that you're someone who can help, you have empathy, and it's not just all in their head, and you have a lot of unconditional positive regard for them. So more diagnostic difficulty, right? The labs typically are normal, in this world, conventional labs, and we'll go through all the labs I do. No specific tests available. Most patients, they're either partially, completely disabled by manifestations. Illness has a pattern of remission and relapse. They look healthy, right? And you see this a lot in autoimmune diseases. There's a great rheumatologist mentor of mine that wrote a book that said, you don't look sick. And it's about how people really are sick, but they may not manifest it. Like if someone has ankylosing spondylitis or, something like that. Accused of malingerers worsening their physical and mental symptoms. And that's who I mostly see, where nobody believes him and they just think they're crazy and want to put them on antidepressants. Or even the family, right? They don't believe it. So there's huge overlap, right, between chronic fatigue syndrome and fibromyalgia. And again, it's one of these things that they have chronic fatigue that causes fibromyalgia. They have fibromyalgia that causes chronic fatigue. For me, I don't really care. I treat the person. This is what they have. If they've got much more musculoskeletal pain, I'm going to treat that versus the CFS patient that's really just wiped out all the time and maybe has some orthostatic hypotension. So there's a huge overlap, right? 80 to 90% are women, usually 20 to 55. The myalgias and fatigue at about 90%. Common overlap in the cognitive dysfunction, mood disturbances, lots of headaches, sleep disturbances. No known cause of either, but we'll go through that. We do know at least some correlations that can give you inroads to treat, and we'll go through that in a minute. Testing is usually typically normal labs, chronic symptoms, no highly effective therapy, right? This is straight out of up to date. But not in my world, and most of our worlds in integrative medicine. Right, so these are not me. These are conventional, high profile journals. They're saying, well, this is what we think is causing it. So you got infections and, viruses and bacteria. And I really should probably add, now SARS-CoV-2 into this. So Epstein-Barr, herpes simplex 6, cytomegalovirus, right? The list goes on and on and on. And what I tell patients is that, we can't test you for all the infections in the world that can affect humans, but we can test the most common ones. And then you can also look closely at the CDC and see if there's, some lymphopenia, neutropenia, those kind of things. And then you can start testing. But the ones I run because I see it a lot, would be Epstein-Barr, herpes simplex 6, and cytomegalovirus, mycoplasma pneumoniae. And then depending where they're living and if they live in, an endemic area of, tick-borne illnesses, then I'll add those on, which we'll talk about in a second. We know that there's immune dysfunction compared to healthy controls. So when you have these individuals, they see decreased immune complexes, decreased natural killer cells and function, altered IgG levels, altered CD4, CD8, increase in interferon and cytokine activity in IL-2. So we know there's something going on. It's not all in their head. And then we also see this physical emotional stress commonly reported, right? You get this HPA axis dysfunction, which we all know well. And I think it goes farther in most patients, not just CFS, right? It's more like hypothalamic, pituitary, thyroid, adrenal, and in women, ovarian, and men, testicular axis, because it's all in crosstalk. So it's more than just, the hypothalamus, pituitary, and adrenals. That's why a lot of people who have, hypothyroidism, right, and they're stressed out all the time, and cortisol is really elevated, and they can't convert T4 to T3. The brain thinks you need to have more thyroid, so TSH spuriously is elevated, and then the person gets thyroid medication, they feel worse. Wrong gland. Treat the adrenals, thyroid corrects itself. So you got to look at the whole picture, right? And that's what we do as holistic care providers. Other etiologies, and I wouldn't say that this is an etiology. I just put it there because that's what the science says. I don't agree with this. I don't agree that POTS causes CFS. I think POTS is a manifestation of CFS, right? Where these people develop low blood pressure and tilt table. You can even do Hall-Pike sticks, and you'll see things like that. Lightheaded, visual dimming, their heart rates might be elevated because they're trying to keep the blood pressure up, but their blood pressure is like 90/50, and they get lightheaded from sitting to standing. Just give them some more salt. That usually helps. And then adrenal support. We'll go through all that. Neuropsychiatric factors, again, they say that 2/3 or more meet the criteria. And I have a lot of patients that get put on antidepressants, but that's not their issue, right? It's a manifestation disease. That's a Band-Aid. And then because they don't need it, they feel worse and they get all the side effects, of the anxiolytics and the SSRIs, the SNRIs. I'm not anti-medication right there, but you have to use them in due diligence and use them when they're needed, not just haphazardly just give people a whole slew of, medications. And then genetics, right? We know that the DNA sequence changes in this population that has changes in brain function, stress, emotional response. Basically, in other words, they just have a lower threshold to stressors. Makes sense. It's like people in chronic pain, right? If you're always in chronic pain for years, your barometer, right, your fuse is going to be a lot lower than someone who's healthy. So what about genetics, right? I like these papers because genetics, to be with anybody's health conditions, chronic health conditions, genetics are always at play. And here was a study where they looked at a bunch of people who had chronic fatigue syndrome versus a healthy, normal population. And they found polymorphisms in this HPA axis function, neurotransmitters, nuclear receptor subfamily. I'll spare you the long words. So they're saying, even in this journal in pharmacogenomics in 2006, right, 15 years ago, that we know it's heterogeneous, and here's evidence showing there's your genetic propensity, just like most diseases. That why would patient A get it, exposed to something and end up with chronic fatigue syndrome or an autoimmune disease, or cancer, and why would subject B not? Usually genetics. This was a great paper that, same journal. What they did actually was they looked at all of these SNPs, right? And they came to the conclusion that there's 28 out of millions of possible single nucleotide polymorphisms that predict whether a person will have CFS with 76% accuracy, right? This is more that would be in an institutional study, like a university, more research, right? Because you want to get the person, you're not going to run these genetics and say, look, your whole life, you have a 76 probability that you're going to end up with this. It's just nice to know that all these genes are at play. And if you look at what these genes are doing, right, a lot of them are producing neurotransmitters and helping with hormones or breaking the hormones and neurotransmitters down. So it's no wonder they've already got this HPA axis dysfunction, because they're genetically susceptible to it. Then there's mitochondrial dysfunction, which again, I believe is a manifestation, because we know all these infections or certain medications, and et cetera, they are mitochondrial disruptors, right? And they really mess with mitophagy, and then you can't replicate, you have that normal turnover of mitochondria, they're damaged and produce new ones. So this is an inroad, and I see this is the number one mistake I would say that patients come in with me, is that, you know, they're reading stuff online. So you got Dr. Google, you got the person at the health food store, you got their neighbor, their family. Everybody has, you know, good intent. You know, they're trying to help the individual, and they usually just like, well, you need mitochondrial support, right? And we're just going to blast you with all these mitochondrial cofactors. And you see with these individuals, they spend a ton of money and they might get 5 or 10% better. It's because they're not treating the underlying cause, which is damning the mitochondria. And usually if you get to the underlying cause, a lot of times you don't even need to do mitochondrial cofactors and repair, because it repairs itself. We'll go through all that. Another paper talking about metabolomics, right? The study of the breakdown of metabolic pathways in the body, like what happens when you eat food or you detoxify something. And this was a great paper. It's super heady. It's, you know, it's hard to read the whole thing. It's great if you have insomnia, kind of puts you right out. But here they're talking about people who have chronic fatigue syndrome. They actually showed they were in a hypometabolic state 24/7, and even worse when they would eat supplements or they would eat foods. Right here, they're talking about abnormalities in sphingolipid, phospholipid, purine, cholesterol, microbiome. You know, I mean, the list goes on and on and on. So here's another reason why that you can blast them with all the metabolic cofactors, mitochondrial cofactors you want, and try to stimulate their metabolism. They're not going to get that much better, right? Our goal, at least my goal, is I want to go for the cure whenever possible and give them their life back. And this paper proves my thoughts. So why I give this talk a lot, or ask to give this talk a lot, is okay. So what's Dr. Bourne doing? What's he doing different? You know, that, you know, ruling out all other ideologies of fatigue, right? I know it sounds simplistic, but it really is. And I'll give you an example. So I had a patient in Connecticut when I was practicing there, who he had a couple health issues. One of them was chronic fatigue, and so we went through everything, and I literally just ran some basic labs and then checked him for tick-borne illnesses. And he was severely anemic. Sorry if you guys are getting feedback. I'm getting a little bit on my end, but that's okay. It's resolved now. So he ferritin was like 10. He had stage 1 and 2 iron deficiency anemia. And I asked him if anybody had ever looked at these. I mean, his crit was low. He was like, yeah. And I said, well, you're not a vegan or vegetarian. And why? And he was a high functioning professor at a university. He was a mixed martial artist. He wrote 10 books. He's 5th degree black belt. He's like, I can't do anything anymore. I think I'm out. He had to go to part-time work. And so I was like, did anybody, were you, you know, you're a man and you're not a vegan or vegetarian, means you're bleeding from somewhere. You should not be this anemic. And he didn't have celiac disease or malabsorption disease. And he's like, well, I know it's kind of embarrassing, but I have these really, really bad hemorrhoids. And he's like, they bleed, you know, profusely. And I was like, well, there you go. That's why you're anemic. And so I inspected them, and I mean, they were large, and I was like, wow. So I sent him to a gastroenterologist, and then they worked him up and said he had grade 4 hemorrhoids. We did surgical repair. He's like, these are not, you know, ones that you can do outside of surgery. Fix those, replete him with a bunch of iron. He was fine, right? And he was like, he was very pissed at his, you know, his cardiologist and his endocrinologist and, you know, his GP. And he was like, I've been sitting here for 10 years and you're just telling me I had iron deficiency anemia. I was like, yeah, sorry. So that's all it takes sometimes. Of course, we would love those slam dunks with this condition, and that's more of an extreme case of simplicity, but just to show you that it just takes somebody to slow down, run more appropriate labs, and look at them closer, and then talk to the person, right? And not be in the room for 7 minutes. So ruling out other etiologies, right? So you got psychogenic causes, they have sleep dysfunction, and you have organic causations like, you know, hypothyroidism or iron deficiency anemia. I look at a lot of the comorbidities, fibromyalgia, sleep dysfunction, you know, are they having POTS because of the fact that they have reactive hypoglycemia? They you know, postprandial syndrome. they have psychiatric illnesses. You just got to look at everything. And that's why the first appointment with me is, 60, 75 minutes, depending how fast they talk and how quickly they can relate their story to me. Then, the routine labs, and it doesn't mean I'm running every single one of these all the time. I mean, I'm running a lot of these, but it depends on the case history. But, CBC, thyroid panel, iron, all the stuff you guys are used to, looking for, autoimmune disease, looking at thyroid antibodies, TSI for Graves and TPO for, Hashimoto's, etc. Then kind of more advanced approach. And, looking at methylmalonic acid, RBC zinc, along with serum, right? Because it's an intracellular cation. It's hard to assess unless you're going to do a magnesium load test. And, it's practical in clinic. I like ionized calcium, RBC zinc, iron panel, right? And then I'm running hormones, DHEA, sulfate, pregnenolone, testosterone, fractionated estrogens. And even in the younger folks, you'll typically see these hormones low. And that's right, because they're just stressed out all the time. They're really sick. So they end up being in that world where, you're robbing Peter to pay Paul. So they're shunting towards other steroid hormones. And so DHEA goes down, testosterone, everything goes down. I never really give them hormones right away, because if you fix all the other things, hormones start to normalize on their own. And sometimes you may have to fill it in. Like I use a lot of pregnenolone and DHEA. I don't use a whole lot of these unless I really have to. And then this is key. So now I'm gonna start looking at infections, right? Particularly if they come to me and they're telling me that they have a sore throat that comes and goes, they have cervical lymph nodes that swelling that comes and goes, they feel febrile that comes and goes, they have this waxing and waning of symptoms. And the reason that is, right, because if one of these viruses, they're all in the herpes family, which we never fully clear, right? Herpes viruses always live inside us. The point is just to knock them down as much as possible and keep the immune system strong enough to where they are no longer an issue. Right? I mean, what's the number one cause of a herpes outbreak? Chronic stress or shingles when you get older and a weakened immune system. These are all similar. So as the virus replicates, and this is what I explain to my patients, so the virus is replicating, your immune system is prompted by lymph node swelling, and sore throat, and a fever to try to crush and kill off that virus that's replicating. Virus dies off, you feel good, it replicates, you feel poopy again, and people do this roller coaster and they either get better or they go so long that they don't even go up and down anymore. They're just sick all the time. And that's because the circulating pool of white blood cells has mostly been depleted. And you can see that on CBCs, right? You'll see low white blood cell counts or even low normal, low lymph, especially if you do the CBC with, an expanded CBC, you'll see the neutropenia, lymphopenia, those kind of things. I start talking about tick-borne illnesses, and my lab requisitions, I just have custom panels and they're paper. I'm old school. I just click the, tick-borne illnesses. So I'm testing for Borrelia, Ehrlichia, Bartonella, Anaplasma, all at once, right? And if it's in the Rocky Mountain area, I'll add on Rocky Mountains rickettsia, Rocky Mountain spotted fever. I always add mycoplasma, IgG, IgM. I don't do mycotoxins right away. This is like if everything is normal or like they're not responding to treatment, I do start talking to them about mycotoxin testing. There's only one lab that I use, and that would be my MycoLab, which is Dr. Andrew Campbell's website. He's one of the foremost world-leading experts in mycotoxins, and it's blood, it's antibodies, because most of the mycotoxins, right, in urine, they're not useless tests, but a lot of them, they're bound to albumin, so then they don't pass through into the urine unless you have kidney disease, and you can't really pick them up as well. So, and he's got great papers if you want to know more about why antibody testing is more accurate. And then I kind of look at urine and blood heavy metal assessments, unprovoked 24-hour urinary toxic metals from doctor's data, because if I've been doing this long enough, and all of us have been doing this long enough, that you should be able to have what you think is your working diagnosis, do an intervention, and the person should respond, right? It's pretty predictable. If they're not responding, it's either that one, what you gave wasn't a high enough dose, they were not adherent to what you said, your differential diet, your diagnosis needs to be reworked and go back to your differential, or there's something you're like, nope, those were all fine. What's going on here? Something's in the way. And then I'll start looking at heavy metals interrupting my treatments and why they're not responding and getting those metals out. So these are kind of more when I've been working with them for a few months and they're not responding, and I'm like, all right, we got to look at something else. And then people were like, well, that's a lot of blood, you're known as a vampire. And I said, I am, and there's a reason, right? Because people are really sick. I do talk to them about insurance coverage. I usually say, what is your insurance coverage like for labs? Because these people are really stressed out. They've usually spent a lot of money trying to get better. And so I'm going to straight up ask them. I don't want to be the person who adds further burden to them by running $3,000 in labs that aren't covered. But most people have really good insurance. So I blast that lab rec with ICD-10 codes, right? And the reason you do that versus like super bill or building insurance is that you can load those super bills, those lab requisitions up with ICD-10s, because those tests get assigned to different codes. That's how you get them covered. So I've had people, thousands of patients, come back to me and say, I mean, how did you code this? Because they took 16 vials and I got a $50 lab bill. This is how you code it. And it's not doing anything illegal or nefarious. You just got to basically know how to code. And the reason, these are different codes that are relevant for infections. I like a lot of these unspecified codes, like E63.9, because that tells the insurance company you don't know what this person has. You're working them up, and it does get covered, and these will even be covered by someone like Medicare, right? And they don't cover anything. So the EBV panels, and this is another mistake I see most clinicians make, is they only run 3 out of the 4 aspects of the Epstein-Barr virus to truly know if someone has a reactivation. And most of these panels, like LabCorp, Quest, Kaiser, their panels don't even include all 4 of these. So again, it's a custom panel. So you need to run the viral capsule antigen, IgM, IgG, the early antigen, and the nuclear antigen to really know. And this table is actually just from LabCorp. This is how you look at it to tell if the person who's had past infection primary or they really have reactivation. And most of the time, the patient will fall into one of these. Sometimes you get these weird nebulous ones where it's like they have all the signs and symptoms, but like maybe the early antigen is not as negative. And this has to be a quantitative test, not qualitative. You don't want plus or minus, because 90% of the industrialized world in North America that have been exposed to Epstein-Barr when they went to college, they may have never got mono, but they have the virus and they have antibodies. So you need the actual titers. So that's the other key thing, because those titers, the higher they are, obviously that infers more viral load. So what's conventional medicine going to do, right? They're like, you're going to do some CBT and you're going to do graded exercise therapy. Maybe some antidepressants, and then if they don't sleep well, get them on some sleep support groups, which I'm a big fan of. And then this was an interesting study in people who had normal crit and hemoglobin, but they have low serum ferritin. They actually condone treating them with iron, and people improve versus placebo. And this is a no-brainer to us, right? Because you have stage 1 and stage 2 iron deficiency anemia. So a lot of times people will run a crit without an iron panel, or they run the CBC and they're like, you don't have iron deficiency anemia. That's because ferritin hasn't gotten low enough, and the body's always going to take everything from everywhere to keep itself happy and running and normal. So I like to treat ferritin. And it's an acute phase reactant, so you got to be careful of that, right? If it's spuriously high, but I like to see it around 75 in patients. Doesn't really need to be higher than that, because iron is damaging. I'll kind of lean to the side here a little bit so the sun rising right in my face. Conventional treatment, right? Here's just another thing, reiterating it. And here's the studies. So I would say that these are naturopathic strategies, and right, you get 1 disease and 10 naturopaths in a room, you're going to get 100 ways to treat something, and that's not a bad thing, right? That's the whole point of kind of holistic and personalized, medicine, to treat the individual. But I like to do things, much more strategic and systematic. So here they're talking about 2/3 of people with, chronic fatigue syndrome. They reported that they were dissatisfied with the quality of their care and felt that their clinicians didn't know anything and were dismissive, et cetera. So just the listening is going to help, right? That someone is, listening, understanding, and has options. They really like that a lot, right? And then trying to find accurate underlying abnormalities, address accordingly. Not everybody is a person who would benefit from counseling or support groups, but I usually ask them. Some people, most people, right, we're as humans, we're gregarious individuals. We need that connection. And many people are like, yeah, I want to talk to people who feel like I do. Am I the only one out there? Some people are like, no, they're the lone wolf. They're like, I don't want to talk to anybody. Okay, you don't have to. Just, it's out there, support groups, whatever. Counseling. I'm a big fan of and finding the right therapist, right? Not just the cookie cutter talk therapist. The person goes in, once a week for the rest of their lives, and they don't really get anywhere. I like the more unique therapists. But I'm also going to match the therapist's personality and style to my patient. If I have like a hardcore engineer that just wants science of everything, I'm not going to send them to the woo-woo right therapist who's going to be doing yoga therapy and talk therapy, and other kind of mindfulness-based meditation that they're not going to be into, and they're going to be turned off by it. Of course, sleep hygiene, and most of them, it's not their fault. They're just so messed up, for lack of a better terminology, that their sleep's all screwed up. So you got to get that reset. Diet, and we're not doing all this at once, right? The hardest thing to change for people is their diet. And you got to get them feeling better. If they're wiped out all the time, you can't start having them do allergy elimination diet and all these complicated things. Constitutional homeopathy, which Dr. Bill and I have had some fun communications via email, how we love it, but a lot of people hate it. It's the most contentious modality in all of medical world, right? No matter what kind of practitioner you are, people either love it, they hate it, it's quackery. But I can tell you in my practice, it is my #1 tool to treat any disease. And we'll go through what I do with that, because that helps with their flares. Instead of giving them tons of supplements, you can treat everything at once: the mental, emotional, physical, spiritual, mitochondrial support, botanicals, antiviral, immune. So history and physical exam, look for themes and trends. That's really important, right? The waxing and waning. Some patients are like, no, I don't get any of that. Pharyngitis, lymphadenitis, fever. That's going to lead me away from infectious causation. They're just, then I'm thinking, well, what else do they have? Do they have mold toxicity, mycotoxins? What's going on here? Constitutional homeopathy, blood tests we went through. And then I always end up giving them a remedy at the end of the first visit, 99% of the time. And, now I just mail it to them. Doesn't matter where they are in the world. And then I have them come back in 3 to 4 weeks. And I'm like, what do the homeopathic do and not do? And what did the whole boatload of labs show? And then also I usually get the last 6 months of labs from the doctors that they've had before. And if they're positive with Epstein-Barr, cytomegalovirus, and or HHV6, or all of them, I'm going to treat them with chemotherapies. So chemotherapy is, when I first heard that, I thought it was, I was in medical school, I thought it was gemstones. And I'm like, I'm not really the gemstones. It's not for me, it's for other people. And my botanical medicine professor is like, no, it's totally different. Chemotherapies, if you're not familiar with them, these are literally herbs on steroids. So what they are is, it's part of biotherapeutic drainage. They've been around for about 150 years. And what they do is it's either the young shoot or the root or the bud of a plant, and it's picked at the right time of the year. So it's kind of a spagyric way of doing things, alchemic way, as you picked at the right time. And then it's then macerated in, depending on the company, alcohol, glycerin, water, and then for 30 days. And then it's diluted to a 1 to 10. So you're getting more of that energetic, but there's still a physical substance there, and you're getting more nanoparticles, except for a couple of them are toxic, like viscum album. So it's diluted to 1 to 100. And then because biochemically, right, it's the plant, it's where the plant is budding, or the young shoot, it's putting all of its energy into there, all of its DNA, all of its nutrients, because the plant is growing. And it's also very sustainable because you don't have to pick very much of it when you're diluting the mother tincture to a 1 to 10. So it's very sustainable. And then it also has to be harvested a certain way. And then energetically, you're getting all the goodness into the plant. And so these do work very, very well. And there's, probably 150. And, there's different companies out there. I have no affiliations with them. I use the company Unda, which is out of Belgium. It's carried by Soroil. You can get them on, Emerson and FullScript, buy them direct. And then I'm using, so the Acer campestris, juniperus, communis, and tamarix, which is, I think, English maple. This is English maple, and then Tamarix is just Tamarix. And then you add in this oligo element, which is copper, gold, and silver. And oligo elements are essentially minerals that are diluted into physiological dose versus pharmacological dose, right? Giving someone 25 milligrams of zinc, it's a pharmacological dose. And then they're ionized, they're already charged, right? Most minerals get their ionization from, hydrochloric acid. These are already ionized. And this literally just supercharges these. And, gold is used in Ayurvedic medicine as an antiviral. It's also for fatigue. And again, you don't have to worry about people getting ajaria from, too much silver. They could drink bottles of this stuff and they wouldn't get, turn into a Smurf. And they do this for about 6 weeks. And these are in 4-ounce bottles. So I just tell the patient to, buy an 8-ounce tincture bottle. They can use a mason jar if they want. Most just get the tincture bottle. They get an 8-ounce bottle and they fill that 8-ounce bottle 1/3 full of each one of these 3 chemotherapies. And then they shake it and they take a teaspoon in the morning and a teaspoon before they go to bed. They don't like the taste because it's very strong and alcohol-y tasting. Then you put it in water, an ounce of water, juice, doesn't matter. And then you take 1 dropper full, so about 30 drops of this with the gemmos. And, I would say, we'll go to the next slide. People within the first week, if it's reactivated virus that's causing this problem, they feel better, and they'll email you and be like, oh my God, this is amazing. I've never felt anything like this. What would you give me? And then of course they feel good for like a couple weeks and they kind of plateau and they get a little bummed because they felt so good. And then you just got to tell them to stick with it. It takes about 6 weeks to finish the herbs. Sometimes people, they're just sensitive, right? Like anybody. And they always kind of report to me the same thing, maybe 10% of the time, but they feel weird. That's all they say to me. Like, I feel kind of weird on this treatment. I feel a little out of my body or out of my, like up in the ether. Like I had one guy that just emailed me from the UK, and he's just like, I have like an out of body experience. I said, just take half a teaspoon twice a day for, a couple of weeks and then ramp it back up. I've never had someone where they couldn't tolerate this treatment. Some are really sensitive. We might have to go to like 1/4 teaspoon once a day for a week or 2, but that's still not that common. It works even in the very sensitive. And then what they do is they come back right after those 6 weeks. They usually feel about 75 to 95% better if it's the Epstein-Barr cytomegalovirus kind of thing. And now I am going to start getting their immune system up to speed and helping out with that HPA axis. I'm a big fan of multivitamins, right? Most people eat garbage. That's why it's called the standard American diet. And even if they do eat well, their body needs that extra support. They need the B vitamins for neurotransmitters, and they need the zinc, and they need the D, and they need the A for the immune system. Instead of giving them lots of supplements, I just like a whole food, 2 tablets a day, multivitamin. If they need iron, I give them one with iron. Nope, they don't without iron. I'm not into these like 6 monster a day crazy capsule loads, and then their stomach hurts and they're, they don't feel that great. And then I'm gonna start cleaning up the gut, as we saw earlier. We know that there's gut microbiome dysfunction, fermented foods. I have a handout that also includes the stewed apples recipe. I want to do things through foods, particularly because probiotics are great, especially when they're high quality and they're dairy free and they're shelf stable, et cetera, versus most of the probiotics in the market. They are garbage. They're either contaminated with pathogenic bacteria or they don't even meet label claim. So you got to get them on a good one, but they only infer a health benefit up to a certain point that they take the probiotics. For a few, there's a washout period, depending on the genus and species. So the prebiotics, right, those insoluble fibers, that's what helps their healthy flora to grow. So they really need prebiotics, probiotics, and then this non-colonizing beneficial yeast, which is great to upregulate secretory IgA and help with that. That's the major immunoglobulin that lines our mucosal membrane. So it's really important that they start getting this immune system up, so then the virus gets kept in check. So again, so now they come back at 6 weeks and they've done, the chemotherapy, they've done the constitutional homeopathic, And now it's been, between, depending on the person, between like 6 and 10 weeks. And 98% of them are about 90% better. They're like, this is crazy. I've never felt like this. I'm totally fine now. And this is me, but if you count all the doctors over the years I've taught this to or whoever, and then they've come back and told me that it totally works, it's over 1,000 cases. So it's not just, me having some magical pixie dust that seems to be working. It works over and over and over. So those that aren't better, so say, let me step back. So they're no more symptomatic, but they still have fatigue. Then I add in this ribes nigrum, which is blackcurrant gemotherapy. It is very young, tonifying, very stimulating herb. So I usually start people with like half a teaspoon in the morning and like a quarter teaspoon at noon. And I just say, watch yourself. If it makes you feel kind of, like you're crawling out of your skin or anxious, you got to take less. But some people need a teaspoon. And it really is great for fatigue and repairing the immune system. It's got some steroidal properties as well. So, but they're not a lot better, but say they come back, they're like, I'm like 70% better. I still have some fatigue, but I'm still getting that sore throat that comes and goes. I just repeat the gemos for another 6 weeks, and then they're usually 100% better. And then of course, no one's textbook. There's usually like, oh, you gotta get rid of the, the help to sleep, help with their muscle pain, help with them getting every cough and cold, the more simpler things to deal with. But if they don't tolerate the naive, there's also the adaptogens, right, which are great. And then they run on a spectrum, right, from very stimulating like rhodiola and panax ginseng to the cooling, more calming like American ginseng or ashwagandha or holy basil. So it kind of maps the adaptogen to your patient. If you have that wired, tired person, you don't want to give them stimulating adaptogens. It makes them worse. And they'll tell you that. They're like, I just feel speeded out, thanks. And they're all aggressive. So I should probably change this now that I've seen 500 or 600 cases of like 5% non-responders, right? So I will actually add in antivirals to the treatment. And I usually end up just going with like valacyclovir, Valtrex, right? It's cheap, give them 1,000 milligrams 3 times a day for a month with some liver and kidney support, and they usually respond quite well. I put all these in there just because there's studies. There's studies for valganciclovir and famciclovir for people who actually were refractory to acyclovir and valciclovir, and they responded better. I've used these a couple times, but I've had patients say that their insurance didn't cover it that well, and I'm not as familiar with it as the other ones. And I had one patient, could have happened with the other ones. She did get elevated LFTs and some icterus, so I just stopped it, did some liver support, and went away, and I just switched her to humic acid and some other ones. So humic acid, I just put it in here because I have friends and colleagues in the UK that love this stuff and they think it works for everything. I haven't seen it honestly work that well for Epstein-Barr. I've seen it work great for herpes simplex when people are getting, I know it's the CFS talk, but just a clinical pearl in my experience, when people are going through that prodrome, you give them 1,000 milligrams 3 times a day of this with some lysine, 1,000 milligrams 3 times a day, and 1,000 milligrams 3 times a day of vitamin C. I've yet to have a patient actually with a herpetic outbreak. And then as soon as the prodrome goes away, they just go down to like 500 milligrams. I've gotten people off of their low-dose antivirals for their herpetic outbreaks as maintenance and given them 750 milligrams a day humic acid, and it's much safer, right, long-term. But there's good evidence of how humic acid works. How it does is it interferes with the virus's ability to attach to the host, get inside the cell and hijack its DNA or RNA. So I've been using it for COVID, but I'm also using a lot of things. So I can't say, it's not been acute COVID, right? These are people who are the long haulers. That's mostly who sees me because they can't see me for acute appointments because I can't do physical exam. I'm limited. So I just send them to urgent care or the hospital if they really need to. So again, so now you're like, well, that's all good and great, but I got these couple people, there's no infectious cause. They don't have any symptoms. Their labs were negative. Now what do I do? And these are the harder ones, but they're still fun, right? The puzzle. That's when I'm going to start being like, all right, I'm going to run heavy metals. It's a $60 test. Molds and mycotoxins, I think it's like $385 or something. So they're not, not something to sneeze at. They could be expensive for people. And they don't accept insurance. I just tell people pay out of pocket, get the receipt, submit that to insurance. Small intestinal bacterial overgrowth. I've had a ton of people come in with these bizarre symptoms. Everything's normal. I test them for SIBO. They got crazy high methane and hydrogen gases. I eradicate this and all their symptoms go away. All their chronic fatigue, all their muscle pain, everything. So don't neglect this. And of course, dysglycemia, adrenal dysfunction, and then kind of, you know, this is really should be everybody if they're not responding to your interventions, looking at allergies, sensitivities, and intolerances, right? And these are totally different. Allergies are a true IgE type 1 mediated hypersensitivity reaction where they can become anaphylactic to urticaria or scratchy mouth. Intolerances are not immune mediated, right? They're only relegated, it's an enzyme problem. It's relegated only to the gastrointestinal tract. You do not get manifestations outside of it. These are the definitions. Sensitivities is the world that you and I all live a lot in. We live in these areas too, but mostly sensitivities where it may or may not be mediated by the immune system. And that's why IgG testing can be limited, because if they're having a sensitivity that's not mediated by the immune system, which is type 3 and IgG, those tests are false, right? They're spuriously false. So that's why the allergy elimination diet is the most sensitive. I had one patient that we did everything. She was really sick for 10 or 15 years, got her about 85% better according to her scale. And then we just treated this, got rid of those things because she felt good enough to actually do an allergy elimination diet. Plus she was cleaned up and the immune system was more balanced, so she wasn't hyperreacting to things. That's right, just a sign the immune system's out of balance. Cleaned all those up. She was allergic to sensitive to a few things. Just did a gut dysbiosis rebuild. I just got an email from her. She's, you know, crying. She's beside herself, has her total life back. She's back to work. She sent me a picture of her in her booth. It was great. She's an artist and sells crafts and things. So still no luck, which is, again, this is not that common, or you got them 90% better. But what else is there to do, right? You got them on adaptogens, you cleared out the infectious causations, you clean up their gut. These are the people then I'm like, I think we just need to do mitochondrial repair and regeneration. And these are the ones, I try to look for formulas that have them all together with magnesium and coenzyme Q10. And they're high doses, much more than you would think, right? You know, you're giving people 600 milligrams. This also works right with fibromyalgia. So lipid replacement therapy, I'll just kind of highlight because what is it is that the theory goes, and the papers are pretty reasonable as far as mechanisms of action, is that with individuals who have fibromyalgia or individuals who have chronic fatigue syndrome, you know, or other, you know, diseases that affect or conditions that affect the mitochondria, is that you can feed them the mitochondrial cofactors all day long, and they're only going to produce so much ATP. It's because the membrane of the mitochondria is leaky. So they're not actually running at top speed. So you need to repair those membranes. And that's easily done by giving people just really high doses of a high quality lecithin. And what I do is a lot of times I just use the company Now Foods because it's cheap, it's really available. They have a non-GMO sunflower lecithin soft gel, and I give people usually 3 with each meal. It's an emulsification, adds in all, and the reason I like using lecithin is because it's all the phosphatidyl groups together and all the glycolipids and glycophospholipids, not just giving people PC. Yes, of course, the membrane is like, what, 80% PC, but your brain and everywhere else in the nervous system still needs all those other phosphatidyl groups, you know, phenylalanine, inositol, etc. So I start repairing their membrane, then I'm going to give them the cofactors. Usually it's all together. I'm like, and I do warn them, I'm like, hey, sorry, it's going to be a little pill heavy for the next 3 months. They don't care because their life being bedridden before to what they are now, and they have their life back. They don't care. They're like, bring it on. And then, you know, giving them NAD, whether you can do this, these are not IV doses, these are oral doses. And most NAD in supplements is not absorbable. It's not stabilized. It's basically nothing. They're not getting much of anything. So you either have to use Niacel, which is from Chromadex, or Panmol, you know, and these are, you can, lots of supplement companies carry these. So just when you look for a mitochondrial form and you want something that's made from Panmol, NADH, or Niacel, a bunch of companies carry it. Sometimes you can get them as lozenges. Otherwise, the NADH it's in products that is not those two is pretty much useless. Sorry, I don't know why that slide's duplicated. So then we got, you know, Other things that I do like these. I kind of like start people off with that first slide, give them, a month or two. How you feeling? They're pretty good. Not enough. I'll start adding in D-ribose. I like these as a powder or a wafer. And then usually you don't. The studies in D-ribose were given right by itself at 5 grams 3 times a day. Like a lot of studies, right? It's hard to give people a whole bunch of things with a known entity and look at a bunch of outcomes because they're confounders. Usually, if people are on those other mitochondrial factors, they only need 5 grams. If you give them more, sometimes they get too hyper and then their sleep gets disrupted or they feel like palpitations. So I usually just get away with 5 grams. These can be found as wafers too. Sometimes because of the pill burden, it's easy to give people wafers, so not just pills. Huge fan of the carnitines, right? And not all carnitines are created equal, right? L-carnitine is what I think more for mitochondrial function, kidney, those kind of things. Acetyl L-carnitine more affinity for the central nervous system. Propionyl L-carnitine more for like cardiovascular function. And it's a lot, right? And it's expensive. Again, if you give it by itself, you need this much. If you're adding it in, you don't need that much. And then of course, alpha lipoic acid. Just be cautious at this dose because it could be cause hypoglycemia. So, and alpha lipoic acid is decreased with meals. So I usually, if people can remember, I'm like, take this 20 minutes before a meal, and I usually give them a 300 milligram. It has a short half-life too, so I try to give them 300 milligrams like before breakfast, 300 milligrams for dinner. If they can't remember to take it before food, still works. You just have decreased absorption, and that depends on their genetics. EFA support that goes along with the lipid replacement therapy, right? You got to get those omegas in there to balance the immune system. Has anti-inflammatory, steroidal properties. It helps with membrane repair. I like to give people in these cases a 3-6-9 blend that has gamma-linoleic, oleic, and then EPA and DHA. If they got a lot of pain, like fibromyalgia, and you can only get this high in liquids. I mean, unless someone wants to take like 10 soft gels twice a day, 1,000 milligram. I usually give them, like a tablespoon twice a day. I work them up so they don't get gastric upset. We talked about the adaptogens before, but now these actually have dosages for you based upon human clinicals. And, the reason some of these are really high doses is because some of them had standardized extracts in the trial and some of them didn't. Notice with Withania somnifera, this Latin somnifera means when you get in these higher doses, it actually can induce somnolence. It makes people tired. So higher doses of Withania actually make people sleepy. Lower doses has that more adaptogen, tonifying, waking up effect. Glycyrrhizid glabra, I like this a lot, right? Licorice, because it's antiviral, it's immune modulating, it has steroidal saponins in it, so it helps absorption with other ingredients. It can be very stimulating, and just watch people with how much glycyrrhizic acid you give them because it can cause high blood pressure. Usually offset by making them eat a banana or 2 a day or giving them potassium supplements since it's an aldosterone agonist. We talked about ribes. One of my favorite herbs, right, comes from traditional Chinese medicine, astragalus. It does everything, right? It's immunomodulatory, it's anti-cancer, it's an adaptogen, it's antiviral. It's just a lovely, lovely herb. It's not endangered in any way. You can dose the heck out of it. Super safe. You don't have to worry about, pulsing it because it's a very safe long-term herb and it's been used thousands of years in TCM. You can actually sometimes get them as in Chinese medicine stores, they cut them in these little like discs or like they kind of look like little tongue depressors. And if you suck on them, if they're bitter in the beginning, but then as your saliva breaks down the polysaccharides pretty quickly within a minute or two, they're actually very sweet tasting and you can get people to chew on these. Helps them when they're working, and feeling anxious or something. Give them to kids, they like them. And then this is just, other strategies because I'm an integrated provider and, I'm a big fan of adding on, when necessary, hormone replacement, IM, physiotherapy. Like I said, I rarely have to go to testosterone. I have one patient now where he's a high profile attorney in Boston and we cleared up, he's actually a COVID long hauler. He had positive mycoplasma, positive EBV because he was been sick for so long. Guy's lucky to be alive. He was hospitalized for a while. The virus is probably just their opportunistic infections. They reactivated. Cleared all those. And then his testosterone was really low and he was doing really well. So I did give him some testosterone to kind of just restart some things. And he said he's feeling great. Now it's time to talk to him about getting off the testosterone. I don't think he should be on it forever. I don't think anybody should be on anything forever. And then other ones, just to know what's out there. I've used them a little bit here and there. I don't use organic germanium a lot because it's very expensive, like $200 a bottle. I just wanted people to be aware that it is out there and have some data. This is actually homeopathic. I've used a couple of times, and it's actually got studies in chronic fatigue syndrome versus placebo. And this is pretty cool, right? In these trials, here's two of the studies that half had significant improvement in symptoms. 1/3 had dramatic improvement. Some of them even saw 100% reduction. And then about 1/8 of all of these subjects actually had slight improvement. And this, one of them was open label, one of them was placebo controlled. So it's nice to know that, there was a placebo controlled trial with Torox that was created for basically chronic fatigue and some other immune dysfunctions. So we'll kind of wrap it up here and then open it up to the floor to questions. I'll try to move out of the sun a little bit so you can see me better. So chronic fatigue syndrome, SCID, to me, it's a multi-system, multifactorial condition. If you listen with an open heart, scientific inquiry utilized, you're going to have some great outcomes, I promise you. Diagnose first, figure out what's going on. Don't shotgun, which I'm not saying you people do this. I'm saying this is what we all see a lot, right? These patients come in with just bags of supplements and they're not any better. And now they're broke because, they're doing Michael Traub's fatigue fantastic protocol for $3,000 or whatever it is. Consider naturopathic therapeutic order, right? When drawing up treatment plans, going from, the simple, least invasive, least aggressive intervention first and kind of working up. Don't overwhelm them. These people are already exhausted. You can't give them a treatment plan with 15 things on there. I usually give people 3, and then keep it super simple. So in that note, I'll open it up the floor to if anybody has any questions. Move over here.
There was a couple of questions in the chat boxes here. There was an answer for one question was, how do you test for mycotoxins? And since we're not CME, you can mention specific labs. That's okay.
Yeah. So I don't use, people are familiar with Great Plains, and they're a great company, but theirs is a urine test. And so most of it just does not pass into the urine. So you're not going to get the full picture. So I use my MycoLab. I'm not affiliated, but Andrew Campbell is a friend and colleague and mentor of mine. I mean, he's the world leading expert on this. It's a blood test. So you just order the kit, you have it drop shipped to your patient or your office. And then for me, because I'm telehealth, it has to be the United States. They will ship out of the US, but then it's complicated because the lab that the kits still have to come back to the United States, right? And they have to 2-day them. It's too expensive, so I just don't bother with it. But I just have them wherever they are. I just have them either usually just go into their local lab, which usually won't draw them, but I have them call a local home phlebotomy company. Since COVID, they're everywhere, right? And then the home phlebotomist just comes to their house, reads the instructions, draws it, and then ships it to my MycoLab.
And do you prescribe NMN supplements for mitochondrial support?
I do not, and that's supposedly, the reason I do not is because the data isn't great. It has no GRAS status yet, generally is recognized as safe. I know supplement companies are promoting it, that it upregulates NAD. Honestly, you can give people niacin and they'll produce NAD on their own. But as we saw in the chronic fatigue population with those studies, is that they have polymorphisms in the ability to make those on their own. So just why not just give them straight NAD? I don't do IVs anymore because, right, I'm a telehealth practice. So I sometimes will refer people out to IVs if they really want them, but I don't use MNN because it doesn't have any good data yet in humans and it hasn't even been proven safe yet.
Okay. Those are the questions in the chat box. Anybody else have any questions, comments? You can unmute yourself. And that was excellent as always, Dr. Bourne.
Sure, thank you.
We're truly blessed to be it for you to spend some time with us here.
Sure.
You're not gonna be able to hear me. Okay.
And so anybody have any questions here?
Good. If it's that thorough, then you guys are good to go.
Yeah, so we're good to go.
I have one question, Dr. Bill.
Sure.
We've seen there's a lot of research on pulse electromagnetic field therapy and both chronic fatigue and fibromyalgia. Have you tested that or had any of your patients or any colleagues use that and had any result?
Yeah, that's a good question. There's kind of two aspects that I've seen is that there's a lot of good data now showing that, with this 5Gs and more Wi-Fi we need because everybody's working home, the kids are here, everybody's sucking up your Wi-Fi. Like my 3 kids are downstairs and, sucking up the Wi-Fi. That does have mitochondrial with certain populations. They're mitochondrial disruptors. One of my professors at medical school, he's a medical doctor who taught our sports medicine class. All of his fibromyalgia patients, if they can afford it, he has them remove Wi-Fi and go into Ethernet cables and grounded internet. And he said they do improve. And he does a lot of the pulse therapy. He's certified in some kind of European pulse therapy, and he gets great results. I've heard a lot of great feedback. It's something I am trained in, but I used to do a lot of low-level laser. I know it's not pulse therapy for people with chronic pain, and that stuff was great. But yeah, I've had a lot of people get a lot of success, or some people will come into me and be like, I did this for a while and it got me 50% better with this pulse therapy, but there's something missing. And that's why I got referred to you. And I was like, well, because we need to find the underlying causes. And then once we got that, the pulse therapy worked a lot much better.
Great, thank you.
Sure.
Okay, another question was how to clarify the silver gold gemma therapy.
Yeah, it's copper. It's all together. It's called copper, gold, silver. I use a company called Professional Formulas because it's a liquid. It's a 2-ounce bottle for like $14. It lasts. They usually have to buy 2 bottles because it lasts about a month. So, and they take 1 dropper full of the copper, gold, silver twice a day with those gemmos. They can put it in their mouth. They can put it in with the gemmos, whatever's easiest for them. For me, I'm just like, any way you can get this stuff down is what we need to do. And it works quite well. And some patients, right, for those homeopathy, like the arsenicum albums of the world, the nervous Nellies, they're going to freak and Google around and contact you because you're going to give them gold and gold's going to kill them. And there has silver and they're going to end up with looking like a Smurf. They're going to have diarrhea. And then you have to talk to them how this is basically nanoparticles and that silver toxicity is not caused by that. And they'll lay their fares. But Professional Formulas, copper, gold, silver is the one I use. That's my favorite. And that's what I've seen work the best.
Okay, there was a question about how to contact you. It's okay to put your email address up?
Yeah, you just forgot a period, so I'll put it in there.
Okay. All right. Somebody asked about low-level laser.
Yeah.
Therapy.
I don't really have a brand that, because they're expensive, right? Just the little wands alone that have like the single beam with the 3 crystals, they could be $5,000 to $10,000. The ones that are the big ones that have the 3 beams that you would use on joints, those things can run you 10 to 20. So just kind of, I don't really have a brand off the top of my head because I never own my own. You can also lease them, which is kind of nice, and they pay. Insurance won't cover them. So the clinics I was at, or when I was at Bastyr, the ones they would just charge like $25 for treatment. The treatment's 10 minutes, and I do chiropractors, so it charge $35. And they come in twice a week for the treatments. And but if you go to some of these, maybe A4M or some of these ACAM, AAEM. I'll be speaking in October down there in San Diego at the environmental medicine. There's usually a couple of these booths. A lot of them will be in, especially with some of your osteopathic conferences. Some one booth will have, and that's a good time to talk to these folks to try to get them at a reasonable cost or lease them, or at least to own versus ponying out, 15 grand, because that takes a long time, right, to recoup that investment. Mm-hmm. So I don't have a brand in particular I like. I'll ask some of the people that I know that use them a lot and email out to the group some names of some brands that people rely on and trust.
Another question, where do we get gemotherapy? I know you mentioned this professional formulas.
So gemotherapy, the one I use is from the brand called Unda. I'll type it in. And you can get them, they're distributed by Soroil Genestra. You can get them from Full Script. You can get them from Emerson. You can get them from the virtual distributors like Dr. Supplement Store, those kind of places. There are other brands out there that are good, like Boiron, who makes homeopathics, is making gemotherapies now. I've only used them recently because they just came out with them, so I don't have a whole lot of testimonials yet. And then there's a company called Herbal Gem, but the dosing is different because they're in, instead of 4-ounce bottles, they're in 15 ml bottles, and they're just more concentrated. The company's great. I'll be honest, their customer service is terrible, and they were always messing up my orders and double billing me and sending me the wrong stuff, sending half of my orders. So it was really occupying my office manager's time, and they were never apologetic. And this went on for like 2 years. So I just stopped using them. I was like, you guys are a pain in the ass. So I just stopped using them, went back to Unda, and I've never had a problem. And Unda is really more readily available than Herbal Gem. So I just stopped. But it's nice to know that there are people out there. If one of the gemos is out of stock, you can get another one. And you can always email me because I get that question a lot. It's like, oh, these two are available, but this brand doesn't have one. What's your second in line brand? What's your third in line brand? To try to get the people, because honestly, those, unless you can get all 3 gemos together, and I can speak from experience, they just don't work the same. So 2 of them, won't work as well as all 3. They just do not have the magical power. And it's not my gemotherapy treatment. I learned it at a conference from Dr. Robert Abel, who's a big gemotherapy kind of guru, if you will. So I can't take credit for the treatment. I could take credit that I simplified it, because his way was, my patients were not adherent. It was too complicated. So I'm like, just pour everything in a bottle and take a teaspoon twice a day.
Okay, but I can only speak for myself, but I think this is the first time I've ever heard of gemotherapy. So,
Oh, good.
We're glad to have you with us.
Yeah, that's good. It's crazy because like Unda, the company, they've been around and from Belgium since like 1950. It's just that in the United States, it's well known in Western Europe and the UK because it's been around for so long. It's probably relatively new to the United States, maybe 15 years, because I learned it in medical school, and that was, 10 years ago, 12 years ago when I was still a student. And there was only one company. Those other companies didn't even exist yet, at least in the United States. So hopefully you guys like it. I could tell you from teaching people this, I've gotten emails and run into people at conferences, and they're like, this stuff totally works. It's crazy. But again, it only works if it's the reactivated EBV or CMV, one of these herpesviruses. If it's another one of those causes, the gemos don't work. It's a different treatment.
All right, that's going to be on our list for a future talk then.
Okay.
Just on gemotherapy.
Yeah, and I have the woman who taught it to me. She lectures a lot on gemotherapies, and she can give you a whole presentation. It can get very interesting because they're all single herbs.
Mm-hmm.
They're just simples. There are no mixes. That's not true. There are some mixes, they don't work as well unless you make your own. The samples work better. So let me know if you ever wanted Dr. DePasquale to talk. Robin she'll crush it for you guys.
Yeah, you'll send me her contact information.
Yeah, I'll send an intro for you
Okay.
and her.
All right, terrific.
I have a question.
For every week.
The Unda is available on Amazon. Is that the same company? Because is that the same store brand from Belgium that you're talking about? It is single formulation, and so I was just wondering if talking about the same company.
You brought the Amazon Pandora's box, right? So the Amazon is obviously, as you all probably know, has been in big trouble with the FDA and some other groups, that anybody can throw anything they want on Amazon, basically. And Amazon, the number one way they make money is from their marketplace sellers, not their own inventory. So they don't care who has a marketplace. Well, that's been to the detriment of society because lots of fraudulent and contaminated products, et cetera, et cetera. So the only way to know, unfortunately, about Amazon is if, when you look at the top, it'll say who the distributor is. Then you have to actually do your patient has to do the due diligence to find out if that distributor is the authorized distributor for that company. So you'd have to basically contact Genestra, who distributes Unda, and say, who is your authorized reseller on Amazon? And then, because there could be a bunch of fraudulent sellers, you don't know if that's the real Unda or not. And that's just the world we live in with Amazon, and that's the extra steps we have to take. And if they say, I don't know, iHealth, which is an authorized distributor for Allergy Research Group, for example, they're like, yeah, we also distribute Unda. Then you know that's who you're getting it from, and you know it's the real deal, because a lot of the stuff on Amazon is fraudulent.
Good to know on that. So,
Yeah, it just says the brand is Unda, so it doesn't necessarily say who the, distributor is. So
yeah, so then that's probably not an authorized distributor, and then that's someone I would avoid if they're not coming, because Unda is out of Belgium, and then their exclusive North American distributor is Soroil, and then Soroil then would have I don't know, I assume Soroil would have an Amazon store, right? Soroil's a big company that's owned by Nestle now because they bought Atrium. So, but Unda is independent. Unda is still owned by the same family. You can Google it and find their website. I think I'm pretty sure it should be in English. I think it might just be in Finnish or something, or but you'll have to look. But yeah, that's at least Unda is not associated with Nestle, but Soroil is a distributor. So yeah, you'd have to find out. But if I saw someone that didn't have like the actual who this distributor was, a way for me to contact, then I would say, to me, that would be a red flag that that's not a legitimate seller on Amazon.
okay, thank you.
Yeah, good luck.
I know it's like, so I do, the PDO thread lifts, and our company where I get them from there was a flood, or we couldn't get them. So I had to look on, to get an alternative site, and whether they sell these on Amazon, sure enough, you can get the lifting threads, on Amazon. So I wouldn't, but you can.
Amazon is, unfortunately, I live in the Seattle area, so Amazon, right, is all over here, and they started here. They are dominating the world, right? And that's just the way it's going, unfortunately.
Okay, so again, we got kudos. So you'll get me information on the gemotherapy expert, and we will have them here.
Yeah,
Okay, that was great. Anybody else have any comments, questions? Anything? So you missed our little intro here. For those of you who were here and didn't quite understand what's been going on, we've been trying to petition the AOA to change our name from rheumatic diseases to integrative medicine, and we've been running into some roadblocks. So that's what that little discussion was earlier in the day. I'm not sure it's going to happen at all, but we'll keep at it without jeopardizing our charter here. So next week we have Dr. Mike Beamer from Amex Pharmacy. He's going to give us the latest on, I don't know about the rest of you, but I mean, I'm getting calls all day long now I'm sneezing, I need ivermectin, and I need hydroxychloroquine. So he's going to give us the latest and greatest on ivermectin, hydroxychloroquine, and what the latest protocols and recommendations are for those things. And he's over here, two boxes to my right. So I don't know if you want to say anything now, Mike.
Well, not in particular. I just invite everybody to come. We're going to talk about ivermectin, methylene blue, and COVID. We've got probably 2,000 patients in treatment, and we're just going to relay the latest recommendations and talk about ivermectin, methylene blue, and any of the other medicines that are in the protocol that you'd like to talk about.
Okay.
Yeah.
Okay. So that's next week. Anybody have any anything they'd like to present. You know, we always need presenters. And Dr. Bourne, again, thank you so much. I think he's dropped off.
Can I ask you a quick question on ivermectin? Is there a maximum dose? I had a 340-pound lady.
Very good question. Okay. You have to, we're going to talk about that, and you need to find a way to calculate a lean body weight. Okay, because there is an upper dose, yes. And I'm trying to confirm that between now and when I speak with you. But I have dispensed a lot of it. I don't really go much over 50 milligrams. And I don't like to. I think I'm getting a little itchy in that area. So when you start looking at these 0.4 and 0.6 milligram per kilogram dosages, you know, so I think what we have to do is we have to look at the obese and morbidly obese patient and then dial them down based on their BMI, or possibly by, and I'm going to defer somewhat to the group and start asking these questions. What would your best calculation be? And then I'll look in the literature. I have a couple of studies on that subject. But the obese patients, yeah, you don't go milligram per kilogram over. If it comes out over 50 milligrams, question it.
Yeah, when I calculated, it's like, this sounds like a
Me
lot.
too.
And I couldn't really find any resource except in the FOCC. There's one little section that the maximum dose was 110 kilograms. So I went with 48 milligrams.
Right. And I think what they're saying is beyond that point, you have to calculate their lean body mass by some method. And I'm looking for if there is an approved method with regard to ivermectin, or something that's been studied, or if they're just kind of multiple kind of, you know, ways of doing it. Cause I know everybody kind of has their own way of doing that. But yeah, so that is going to be mentioned. But I agree with you. I think I wouldn't be going 0.6, that's for sure. 0.4, maybe like doubling up the dosage for active cases and short term. I could see that. But yeah, I would be cautious otherwise, because at some point it will cross the blood-brain barrier. And we do have susceptible receptors in the blood-brain, across the blood-brain barrier, but not this side of it, so to speak.
Thank you.
Yeah. Come next week. We'll talk more. Yeah, thanks very much.
I will. Thanks.
Yeah.
Okay, that's great. Anybody else? Any questions? Any comments? Again, Dr. Burgess and I are putting together our OMED. For those of you, that's the DO's, giant fall conference, October 22 to 24. We're putting together the finishing touches on that. If anybody'd like to present something, let us know. We have to turn things in by the end of the month. So, with that, I want to thank everybody who came. We have some old friends. Dr. O'Neill Smith is here, and Dr. Beamer, our regulars, Dr. Renza, Dr. Spear, Dr. Centric, Dr. Ching. We have some new names here, Dina and Dr. Mulho also, thank you. We have Kate, we have Gabriella Lana, is a newcomer also. And please, we're here every Tuesday night, 5 p.m. The Zoom link that you use tonight is the same Zoom link every week. And if you have friends, colleagues, you have a giant email list, please spread it around. You can tell by the talks that we have. We have a great community. We have fabulous speakers, and in the AOA anyway, this is a unique experience. So again, thank you everybody. We will be here next week. Dr. Beamer will be talking extensively about COVID protocols. And just a little heads up, the week after that, we're going to have Terry J, who's actually a patient of mine. She's a medical intuitive, and she tells us that, and I've seen her in action, and it's unbelievable. She can look at somebody and she can tell me what 90% of the time make an accurate diagnosis just by looking at them. She tells us that she can actually teach us how to do that. So I thought that might be interesting from somebody to talk to. So I told her, I said, I have to send somebody for $5,000 worth of tests. You can just tell me what's the matter with them. So I thought that might be interesting. So we're going to bring her on, and she have her maybe channel us a little bit. So I thought maybe that might be something a little bit of fun. Anyway, so everybody have a great week. Those of us out here in the West Coast, try to stay out of the smoke. We will see you next week. And that's about all I have. The slides from Dr. Bourne's talk are actually already on the website. I'll put it in the chat box for how to find it. It's aosrd.org/webinars. You get it right for once. Yes, aosrd.org/webinars. The slides are up there. I will have the recording on usually within 24 to 48 hours if I remember to take care of it. And because I got Dr. Zarins from a couple of weeks ago, kind of got delayed a little bit, but it's up there now. So anybody else, any questions, comments? If not, we will see you next week. And thank you all for being here and participating, and spread the word.
Thank you, William. Bye.
Thank
Good night,
you.
everybody.
Good night.
Thank you.
Oh, you were sending it to Kathleen.
Oh. Okay. Okay.
Try to speak today.
Spell it right. There we go.
Okay. Well done.
Okay. There we go. Okay.